is John Woody Orfino of the For Karen Initiative. One of the ways in which we want to obviously effectively engage the audience and the community around For Karen is through video, and we have a great opportunity today to be meeting and listening to the researcher, the doctor, where your funds will be going, and hopefully the person that is well positioned to ultimately find a test and a cure to ovarian cancer. So want to introduce Jocelyn, Dr. Jocelyn Chapman here, and we're going to kind of go through a few questions and prompts about ovarian cancer, about the research, about where your dollars are going, so you have a better understanding. But I'll just start it off with, hello, Jocelyn. Thanks so much, or Dr. Chapman. Thank you so much for joining us, or you and me today. To start off, I guess, to the conversation, would love to just hear a little bit about you, your pathway to UCSF, and maybe something that not many people know about you, perhaps.
Yeah, thank you, John, and it's really a delight to be here. I am honored to be a part of this group, and I think advocacy plays an enormous role in our search for an answer to this deadly disease. So my love of gynecology, so I'm a gynecology, which is a specialist in female gynecologic cancers. So in addition to ovarian cancer, I also treat uterine and cervical cancers. And one of the challenges in ovarian cancer has just been that for so long we have been diagnosing this cancer too late. And so I think one of the things that drew me to the specialty is actually some new advances that have been made in technology in the last 10, 15 years. We have a better understanding of the molecular underpinnings of cancer and potentially a real opportunity to move the needle in terms of earlier diagnosis and better treatments. From a personal level, gynecology, so we're surgeons, but we also take care of patients longer term and manage a lot of their chemotherapy treatments. And that means that I get to have really personal relationships with families and with patients, which I just find to be an incredibly rewarding part of my work. What brought me to UCSF? Well, UCSF is a really special place. When I did my training here, both in residency and then in fellowship specialty training in GYN oncology. And when people ask me, and then I've stayed on it as an attending and have a job as a researcher, adjunct position in Dr. Ashworth's lab, our cancer center director, who has a special interest in ovarian cancer. And so what keeps me at a place like UCSF is the people. I think the people who work here are not only incredibly talented, but also very, very dedicated to the mission of this university and the community, which I think is an incredibly special thing. So yeah, I don't foresee, I think UCSF is a huge part of San Francisco, and this has become my home.
That's great. Thanks so much for sharing that. And I think you touched on a few interesting points with respect to why and the why as to why you're focused on ovarian cancer or uterine cancer. And I think being in San Francisco and being in the Bay Area, high tech is at the focal point of nearly all industries here in this area, which kind of leads us to the second question of what is the current state of ovarian cancer? Like, what is the current state of the research going into, finding a cure and finding a test to this disease? And if you had your kind of crystal ball, where do you think, and how long, or what's the journey pathway forward?
Yeah, well, it is I think a very unique time to be practicing medicine or involved in any way in cancer discovery in not only because of the technology, but I do think this city is very well positioned, both because of the university itself and then its proximity to incredible talent in the technology sectors. So, just sort of as the broad view, once we understood that cancer had a molecular underpinning, which means that there are discoverable and predictable changes in the genes that mutate or change, and that is what develops into a cancer. Once we started understanding that, then what we really need going forward is the technology to be able to support all of that. So, which it's an enormous amount of data. I think you guys probably all remember when Craig Ventnor first sequenced his genome and the NIH sequenced their genome. Like, it took years just to put one nucleotide base next to another and discover like what normal genes look like. And so in cancer, of course, we're not only what we're really trying to understand is what the abnormal genes look like, and it requires huge amounts of computing power. It requires sequencing technology that is faster and cheaper, and all of those things have been happening over the last 10 years. And then, so specifically for ovarian cancer, one of the big opportunities that I see, and this is what the bulk of my work is in the ability to potentially detect this cancer early. So cancer is oftentimes incurable or difficult to treat when you diagnose it at an advanced stage, but very often curable, and certainly much easier to treat and cure if you detect it early. So ovarian cancer is one of these notoriously difficult to diagnose early because it presents generally without symptoms until it's advanced. So we need a test that is cheap, easy, non-invasive, or minimally invasive, and is accurate. So we're not diagnosing a whole bunch of people, in error.
Yeah.
And so anyways, so the real potential comes with the knowledge that, so when cancer cells develop, even when they're very small, they'll, a certain percentage of them will die. And those cancer cells will get absorbed into your circulation. And actually you can detect the abnormal DNA from those dead cancer cells in your circulation. And ovarian cancer is is an excellent first application for this because they generally all have the same mutation. And so if we know what we're looking for, even if it's in very small quantities, we improve our ability to detect it. So that kind of gets to what one of the things you were talking about. Woody was, where I see, at least in ovarian cancer, where I see sort of our biggest opportunity to move the needle in this disease is detect this cancer early, because we have been failing to do that since, the disease inception.
And I think that's, again, a good segue into, one of the focal points of the For Karen initiative is, we obviously have, the aspect of fundraising, this groundbreaking research that you're imparting and embarking on, or have been embarking on. The other is awareness around this disease, around this horrible cancer. And, like you aptly put it, oftentimes with an ovarian cancer, it's too late. It has the name of the silent killer. In our instance, we found out that my mom was stage 3, like basically stage 4, very late on. And there was only so much you can do at that stage. So, can you speak to, some of those symptoms that people experience, and if there's anything they should be doing or asking of their OBGYNs to making sure that they're doing the right things early on in the event that they can catch something?
Yeah, no, that's a great question. So, while we're waiting for medical technology to, for our dreams to be realized, which is that there's a universal blood test that everybody can take that will tell them whether or not that mass seen on the ovary is cancerous or not. While we're waiting for that, I think the number one most important thing in terms of awareness is actually being talking to your OBGYN about your family risk of cancer and asking whether or not it would be appropriate for you to undergo any testing that might indicate that you are predisposed to an increased risk for ovarian cancer. So what we know is because about 20% of people who are diagnosed with ovarian cancer are found to have a hereditary increased risk of ovarian cancer. So they were born with a gene that was mutated since their birth, and instead of having, 1 in 75 or so chance of getting ovarian cancer in their whole lifetime, their risk is more like 1 in 5. And too infrequently, we're diagnosing that after somebody has already been diagnosed with ovarian cancer, and it would be our time to increase surveillance or maybe do surgery to decrease somebody's risk is really when they know that they're at increased risk and they're ready to maybe have their ovaries out. That's one strategy that we take with women who have an increased risk for ovarian cancer. So that's kind of the number one thing. The UCSF has a BRCA. We call it the BRCA Center. BRCA is the most famous gene that increases your risk for ovarian cancer, but there are at least 20 or so more. And so we have a hereditary cancer center that specializes in testing and detection of hereditary cancers, cancer syndromes, and actually taking steps to prevent cancer in these high-risk individuals. And then you brought up symptoms, and actually it is an important thing when some interesting research was done about 10 years ago now that asked women who had advanced ovarian cancer, think back over the last 6 months and what symptoms did you have? And frequently women would say, actually I think it was more than like 85 or 90% of the time, they would say, oh, I had a urinary tract infection, but I went and got tested and there was actually no urinary tract infection. And then I thought I had another one. And so they're somewhat vague symptoms, but if they persist for more than a couple of weeks, that's the kind of thing not to ignore and to address with your OBGYN sooner rather than later. So urinary changes in your bowel, any new pain in the pelvis, anything, they're going to be vague. The symptoms are always vague, but when people think back to it, they say, it was kind of vague, but it didn't really go away, and I ignored it. So the key, I think, is not to ignore it.
Right. And so what we're hearing is like, two things, right? It's like making sure that you have the appropriate conversations about your family history of cancer, having those conversations, frankly, obviously with your OBGYN, but, every, doctor that you're seeing.
Exactly.
Two is making sure that you pay attention to your body, whether it's, the bloating, whether it's, changes in your bowel movements, whether it's, the UTI that doesn't, go away and so forth, like take conscious effort in recognizing that might be an issue and, bring that up to your doctor. So I think that's super helpful. So finally, our couple last questions. So tell us about your research. You've kind of alluded to it in a few different answers about the liquid biopsy, but just give us a brief understanding of what you're trying to do.
Yeah. So just to remind the listeners and viewers out there, the liquid biopsy is a blood-based test where we remove blood from a patient and we isolate the DNA that is in the blood sample and perform sequencing on the DNA. And what we're specifically looking for is mutations, cancer-associated mutations in the DNA. And in my case, in my research, what I'm specifically looking for is a pretty limited set of mutations that we know happen in 99% of ovarian cancers. So lots of people in the Bay Area, lots of companies are after a blood test that will diagnose any cancer. And I still think we're quite some time away from that. So I've been focusing on ovarian cancer not only because that's my area of expertise, but also because I actually really believe, because of the molecular characteristics of this cancer, that this is probably the lowest hanging fruit in terms of a lot of other cancers. The reason for that is because while ovarian cancers might look very similar molecularly, pancreas cancer does not generally. 20% of them look one way, 50% of them look another way. And because we're dealing with very, very small quantities of DNA in circulation, it helps if you know the needle in the haystack for which you search, as opposed to if you're just trying to say, oh, tell me what cancer this patient might have. So limiting your search space is, I think, one of the keys to success here, at least as far as the technology stands for right now. So what we're doing in the clinical trial at UCSF is enrolling all women who are undergoing surgery for with a GYN oncologist. So there's some concern that they have a mass on their ovary that might or may not be cancer. And we're drawing their blood before surgery and then doing the surgery for them to remove the mass. Mm-hmm. And if it's cancer, then performing the appropriate staging surgery the way we would as a standard of care. And then in follow-up, checking their blood again. And so we're looking for mutational burden, and we're looking for our ability, how early on in the cancer process can we detect even the smallest amount of abnormal DNA that would tell us this patient had ovarian cancer. And if we can do that for a stage 1 cancer, or even there are some pre-cancerous lesions that we've discovered are in the fallopian tubes of most women with ovarian cancer, then we have the capability of actually having a widespread screening test. So we have 20 patients enrolled so far on the study, and are looking to expand to a few other centers in California. And the money that donations that come in from an organization like Fort Karen is going to be hugely important to helping us be able to enroll these patients and to do this sequencing work.
Yeah, thank you. And, I think one of the challenges that I think often people have with respect to attaching themselves to a cause, or, that like level of barrier to entry that people may have to, jumping over the line and actually donating or supporting or being an advocate, or kind of getting into the playing field rather than, being on the sidelines. This idea is like, what difference can I make? What difference can, my $20 or my $50 or my $100 or $1,000 make to combating cancer? And I would love to hear, you spoke a little bit about, enrolling patients and, making sure that, operationally you guys are funded to kind of do your work, but, where do the dollars go?
Yeah, so they do go to, the potential donors out there and the potential advocates and the potential supporters. I would sort of implore you that cancer is a team sport. I say this all the time. I am a cancer surgeon and I am a specialist in ovarian cancer and I do research, but I sure as hell can't do this by myself. I rely on not only our incredible team at UCSF, but also donations from supporting organizations, from advocacy organizations, from and from grants mechanisms and things like that. So I think every little bit counts. And I think approaching a problem as big as cancer, as big as ovarian cancer, from the team mentality is absolutely crucial to success. So join the team and be a part of this this wonderful organization. But yeah, mechanistically speaking, what happens to the money? So when we have a clinical trial, we have a clinical trial coordinator who has to help me consent patients and talk to them about the risks of getting their blood drawn and the risks of a false positive test. And there's a ton of paperwork whenever you do a clinical trial, because the university needs to make sure that patients' safety is kept in mind, and we have to transport specimens back and forth from the operating room to the pathology lab to my lab, and then also to my collaborator's lab, who's helping me with the tissue isolation. And then sequencing all by itself is pretty expensive. It costs about $2,000 for a targeted panel, which is to say, if you want to look for just 10 gene mutations in a sample of DNA, it'll cost you a couple $1,000s to do that. The primary cost for a study, the patients all volunteer. We don't give them any money, and they are also the heart and soul of a study like this is patients who are willing to volunteer to participate in something like this, and it's a huge gift to the future of science, I think, when people are willing to give of their body fluids and to sign those consent forms. So the primary costs are for hiring clinical research coordinators, and then also for the sequencing.
Great.
My time is paid for by the university, and my collaborators' time is paid for by university. So our salaries are paid for.
Great. That's fantastic, and thanks so much for providing that. I think it's a great way to kind of cap off this conversation that we've had, and underlining this idea that fighting cancer is a team sport. And the community that we're building around here for Karen is hopefully going to be the strongest team on the field. So we really appreciate all the work that you're doing, the fight that you're putting up for all the patients out there, and we look forward to toasting you at the walk and seeing you at the walk. And thank you for everything.
Yeah, I can't wait to meet everybody. And John, thank you for everything that you do. This is an incredible organization you've put together, and yeah, the patients are the heart and soul of this. So thank you.
Of course. Well, thank you very much for the time.